We have a wonderful guest host with us tonight, Dr. Mark Paschen, who's going to be talking to us about obstructive sleep apnea, the dentist's role. So, thank you so much, Dr. Paschen, for joining us. And Dr.
Well,
Paschen,
thank
and yeah, Dr. Paschen has a wonderful presentation ready for us this evening. So, just a couple quick housekeeping items. For the first part of the presentation here, I'm going to go ahead right now and mute everybody's lines. Again, if you would like to ask a question during the presentation, you'll find a chat box in the lower right-hand corner of your screen. You'll also find a raise hand option if you would like to be unmuted to ask a question. But as usual, we will go ahead and open up at the end of the presentation for questions and group discussion, so you can save your questions until then as well. So without further ado, Dr. Paschen, over to you.
Well, thank you so much, Courtney, and thank you all for attending tonight, taking time off from your busy schedule, taking time away from the Olympics. After listening tonight, you will know more than about 80% of the primary care physicians know about sleep apnea. This is just information they really aren't aware of, which is why we as dentists are the ones that have to educate the physicians. They don't learn this in medical school, and we now are learning it at seminars and meetings like this. Okay, we will move on. Courtney is going to be doing the slides remotely from Florida, so sometimes when I'm talking, we may not quite coordinate on the slides, but we'll work it out. Okay, we have just reached the tip of the iceberg. As far as sleep apnea, we're all aware of what snoring is, and most of us are aware of what apnea is when we stop breathing. But you look at this as an iceberg, and what people aren't aware of is what happens underneath the water. You know, all the comorbid problems that can happen with sleep apnea, and our patients don't even realize this. People with sleep apnea don't realize this. Why do you think, you know, they're prescribed CPAP? They don't like the CPAP, so they stop using it, because they don't know that by stop using the CPAP, they could actually die. After all, it wasn't above the water that sank the Titanic. Okay. So these are the objectives for this evening. To be able to recognize your patients who may have obstructive sleep apnea, and to know the protocol for treating or referring your patients who may have obstructive sleep apnea. We'll just go through some simple screening techniques, and I'll go through the protocol at the end. The less you know, the more normal your patients will appear. Isn't that true? You know, when I started out doing orthodontics and doing general dentistry about 30 years ago, I would get patients in who I thought, you know, it would be easy just to treat them orthodontically, and I had no idea what was really going on underneath. You look at something like this. Is this orthodontics only? Would I take this first case there with the open bite and treat it just with orthodontics braces? No. Now I know you have tongue therapy problems in there. You have ENT issues with this young lady, chiropractic issues. You look at her shoulders, how they're imbalanced. After this evening, I hope you look at your patients differently, and you'll be able to recognize different problems that they're having, not just look at them as fillings or crowns or dentures, implants, but look at them as a total health and wellness situation. Okay, this next group here. Would you look at him? I had a physician, a prominent physician in town, who this young man at the top of the screen here, he could have been her son. He was sitting on her lap while I was treating her other son, and I could hear him breathing across the room. And here she was, a primary care physician, had no idea that this is not normal. This is not normal when you see a person like this come into your office. You leave somebody like this, and you wait until they become an adult, and then you treat them somehow, and it's already too late. You want to treat these kids when they're young, and I'll tell you in a little bit why. Person who's tongue-tied here. It used to be they'd go by diction, and they would snip the front of them there if they had a problem. Now we know if you get somebody that's tongue-tied, that tongue's going to drop back in the back of their throat and only make sleep apnea worse. And again, an open bite case like this, They have something called an orofacial myologist. You'll start to hear more about these individuals who treat the muscles of the face and get the patients to breathe through their nose, in their nose and out their nose, which is the way that we as humans are meant to breathe. Mouth breathing is very hazardous. Okay. So why do we need to sleep? You know, it's interesting is nobody really knows for sure. They have theories. There's a thermal regulation theory. And this is interesting because when animals hibernate, they're not really sleeping. They're in what's called a state of torpor. It's the body's natural way to combat extreme conditions like hunger, thirst, extreme heat, extreme cold. These animals in hibernation actually wake up and go back to sleep. They have to reach a sleep state in order to get their body temperature to raise. When they're hibernating, their body temperature is too low and they could die if they don't wake up, go to sleep, and then re-regulate their body temperature. Pretty interesting. We emit growth hormones, different hormones, immune function during sleep. For learning, memory consolidation, we know that if we don't sleep well, we have poor memories. And they're starting to do studies of Alzheimer's patients showing that because of the sleep issues that these individuals are getting as they get older, they tend towards getting more and more into getting Alzheimer's problems. And weight control is huge in sleep. If we do not sleep well, we get what's called a ghrelin emitted. It's a polypeptide, a ghrelin from the stomach lining that makes us hungry. So we don't sleep, we get hungry. If we don't sleep also, there's another hormone called a leptin that is not secreted. A leptin is secreted when we sleep. What a leptin does is it suppresses hunger. And so if we do not sleep, we don't get a hunger suppression, and we also get an increased hunger. It's a double whammy, which is why, when we sleep, we shouldn't have to wake up and eat something during the night. A lot of the obese patients have sleep issues. And we think that we sleep to rest our brains. Well, that isn't entirely true. This positive emission tomography shows that during wakefulness, the little red dots on here is what metabolism is. And you see during REM sleep, part of sleep where the muscles basically are totally relaxed, you have the highest amount of brain metabolism of any of the states, the wakefulness, non-REM, or REM. So people who say that we sleep to rest our bodies and rest our brains, that is not true. We have a lot of metabolism going on while we're sleeping. Okay, so why am I even bothering talking about this? It's because this has become an epidemic in our country. Sleep apnea and obstructive sleep apnea, and so many people aren't quite sure what it is. Well, all these people suffer from it. 40% of adults over 40 snore. And this is an older slide. Now they figure approximately 100 million Americans are at rest. And less than 10% have been diagnosed because, again, the physicians are not looking for this. We're the ones that have to screen for these sleep breathing disorders, and we're the ones that need to refer to the physicians for our patients to get the proper help. The reason less than 25% have been treated successfully is because most of the time the physicians are prescribing CPAP, and 80% of the CPAPs go out of use after the first year. Patients tend not to like the CPAP, and they give up on it. There isn't proper follow-up, and their treatment is finished. And I asked you this question. If you had a risk of a heart attack and you were given medication that you were told this will decrease your chance of having a heart attack, you would take the medication. And you wouldn't stop taking it just because you're tired of taking the medication. Well, unfortunately, this is what's happening with our patients. They're tired of using the CPAP, so they just stop. And their life expectancy can decrease by as much as 10 to 12 years by having severe sleep apnea. Okay. So here it is, just some pathophysiology, real simply. The top picture, normal airflow, where you get air going down through the airway, through the throat. Hypopnea on the bottom left-hand side, which is a decrease in airflow of at least 30% for at least 10 seconds. And usually you have some oxygen desaturation. Oxygen goes down that's available in your blood. That's the hypopnea, decrease in airflow. Apnea is almost a total blockage, at least 90% decrease in airflow for at least 10 seconds. You use the hypopneas and apneas to measure the severity of your problem. We as dentists are able to treat patients that are mild to moderate apnea hypopnea patients, which means that they have 15 to 30 episodes roughly, it has to be under 30 episodes of you have decreased breathing or you stop breathing per hour. It's still quite a bit. Okay. So this is what happens. You get an episode like this. It is really, really rough on the body. You get a patient that stops breathing, so their oxygen level goes down. They go into what's called hypoxia. They get more carbon dioxide because they're not breathing out. pH becomes more acidic, and the heart rate goes down. So when the heart rate goes down, the brain is saying, boy, I've got to get this heart rate going. So epinephrine is released, norepinephrine. Sympathetic response in the heart rate increases. As the heart rate increases, you get smooth muscle contraction. The diaphragm is pumping, trying to get air going out through your lungs, air going out through the airway. You hyperventilate, the airway starts to open, you release a lot of carbon dioxide, and then the body shuts back down and the cycle repeats. Very, very rough on the heart, very rough on the lungs, rough on all the body systems. These are the morbid problems associated with obstructive sleep apnea. People do not realize this. Hypertension, high blood pressure, 40 to 50% of the patients with high blood pressure also have obstructive sleep apnea because of what happens. The heart rate slows down, speeds up, the blood vessels constrict and release. Coronary heart disease, congestive heart failure, all the pressure that's going on with the heart. Diabetes, you don't get insulin release, and if you don't have stage 3 sleep, insulin controls the glucose amounts in the body. You get too much glucose or too little glucose. And also, if you're under stress by not sleeping, you get cortisol release, which again increases the glucose level in the blood. And without the insulin to work with, you get diabetes. Erectile dysfunction, you don't get to release a nitric oxide, which is a vasodilator, if you do not sleep properly. 50% of apneics have erectile dysfunction. You treat the obstructive sleep apnea, a lot of times erectile dysfunction gets better. Again, physicians don't know a lot of this. Renal disease, a lot of problems with renin, angiotensin, with the blood pressure. These things are not regulated very well if you're not sleeping properly. Fibromyalgia pretty much mirrors obstructive sleep apnea. You get very tired during the day with fibromyalgia. You don't sleep well. A lot of muscle aches and pains. Nocturnal strokes, heavily associated with inflammation in the body, heavily associated. 84% of patients that get strokes have some form of sleep apnea. Okay, so predictors of heart attack. You figure if you're just a normal, healthy individual, you have a 1-to-1 chance of getting a heart attack. If you're overweight, obesity brings on a 7 times greater chance of having a heart attack. High blood pressure, 8 times greater, which makes sense. Smoking, 11 times greater chance of getting a heart attack. Look at obstructive sleep apnea. If you have obstructive sleep apnea, you have a 23 times greater chance of getting a heart attack than if you don't have it. I mean, isn't this enough to tell your patients, to get them in for treatment? Unfortunately, they're not aware of this, and a lot of the medical community is not aware of this. Now we are. We're the ones that are in the position to help these people. Okay. You can see I get pretty passionate about this stuff. I just find it is just so important, and we just have to get out there and educate people about it. That's why I found it in myself to really get into this. Driving is a huge risk. They have, there's a truck line in Wisconsin. It's called Schneider Truck Lines. They're the big orange trucks. And they did a poll in 2011 and found that 80% of the truck drivers that drive for Schneider Trucking had sleep apnea. They did a poll of 5,000 police officers across the country. 33% of the police officers had sleep apnea. And children, they're screening these kids in 10 to to 12th grade, just starting to drive, driver's ed in 10th grade. And these kids claim that at least once a week they drive to school drowsy. And the truck drivers are a huge risk. After getting into this, I don't drive by the school at all while school's in session, while cars are going back and forth. And whenever I pass a truck on the highway, I speed past and get as far away from the truck as possible. Just the way it is. There's a real danger out there with driving. Okay. It always takes a while for research to catch up with clinical proof, which is why a lot of this stuff, unfortunately, isn't out there. But people will come into your office and they'll say, well, geez, doc, I only snore. Why do I have to go through all this stuff? I don't have a problem. Well, more and more studies are showing that snores alone can lead to being apneics. They've done all kinds of studies showing that mild apneics can become moderate or severe apneics if they're left untreated. All has to do with the severity of the inflammation. And as we get older, we tend to put on weight. And we develop other habits, which can, again, make smoking a lot worse, which can make snoring a lot worse and create an apneic situation. Okay. They've also done a study, this Canadian study, where they found that snoring alone has led to plaque buildups in the carotid artery. And that's the leading cause of stroke. Plaque buildups, atherosclerosis. So snoring by itself now is considered a risk factor for stroke. So if you get a patient and says, doc, all I do is snore, big deal, well, they're risking themselves. They can get stroke. And you saw nocturnal strokes, 84% of patients with nocturnal strokes have obstructive sleep apnea. There's a connection. And what about the secondhand snoring for the poor bed partner in there? Studies are coming out now showing that these bed partners have decreased memory sensations. They have poor learning skills, decreased reflexes, poor work performance. There are all a lot of problems that are coming in with the secondhand snoring. Okay, and this is interesting. Okay, so you get somebody in and says, doc, my husband or wife, they rattle the walls when they snore. Well, you look at these decibel levels. This is how much snoring is for the decibel levels. Okay. An average snoring is between 69, so you're looking at a snore, an 8,000 watt generator, all the way up to almost a home lawnmower. That is pretty severe for snoring. Speaking of decibel levels, Guinness Book of World Records, loudest dog bark is 130 decibels. And that's in Adelaide, Australia. I just thought I'd throw that out there. I thought that was pretty interesting. Okay. And your patients will come in and they'll say, well, hey, I snore, I know I don't have apnea. Or they'll say that I'm not tired, so I don't have apnea. Okay, well, you may not have apnea even if you snore, and you don't have to have daytime sleepiness to have apnea. The only way to tell if you have this or you don't have it is by getting tested. You need to have a diagnostic, a polysomnogram at an overnight sleep lab or a hospital in order to tell. You can't go by what your patients are telling you because you don't know. Okay. So we have some real simple, quick screening things that you can do at your office. You're saying, well, geez, I don't have time. My health history is already filled with stuff. Now, when am I going to have time to do this screening? This is a real quick one. You go STOP, stop. And this is so accurate. It has such a high sensitivity. If you have two of these four things, if you have observed snoring at night, if you're excessively tired during the day, if your observed breathing has stopped at night, and you have high blood pressure, 2 out of the 4 of these, you have a very, very high probability of having a high risk for sleep apnea. This has become so accurate, they're using this in emergency rooms across the country now. The last thing they want is somebody coming in a trauma case and dying in the hospital that night because they didn't have their CPAP or sleep appliance with them. They're screening the patients with STOP. Okay, another simple screening thing that you can use is called BANG, B-A-N-G. BMI is body mass index. You can get charts. You can copy them off the internet, and it relates body to height to weight, and anything over 30 is considered obese. high chance of apnea. Over age 40, high chance. Neck size, greater than 16 inches for a female, greater than 17 for a male. Is the larger the neck, the more pharyngeal fat pads you tend to have in the neck, the more apt the neck is to collapse during the evening while breathing. And gender, men are much more prone to apnea than women up until the time of menopause, and then it's about the same. Okay. So here are the main risk factors, really. And again, this kind of repeats the stop bang a little bit. Obesity is number one. It's huge. And the reason sleep apnea has become an epidemic in our country is because obesity has become an epidemic. The rate of obesity has more than doubled in the last 20 years in the United States. Men, again, menopause, increased age, anatomical abnormalities. You get somebody with a large tongue. You get somebody with a high palate. You get somebody with a setback, a heavy class 2 lower jaw, impinging on the airway, compromised nasal passage, people that have had nose surgeries, deviated septum. Family history is huge. If you had a mother, father, grandfathers, grandmothers, sister, brothers that have sleep apnea, high chance that you have some. And intoxication. Alcoholics, some muscle relaxer, again, tends to relax the muscles while you're sleeping. The airway can collapse in. Major risk factors. Okay. So here's another simple way you can screen. And this is neat because the Nierman program, they can put this right into Dental Writer. Now, however you want to do any of these questions can be put in Dental Writer. I really like this one because it covers everything. The top of the chart, you can do the BMI. The middle there, they have the comorbid issues. High blood pressure, diabetes, stroke, depression is huge in sleep apnea. And then they go to the middle, they have what's called the Epworth Sleepiness Test, measures the amount of daytime sleepiness that a patient has. Insurance companies really look at that. A lot of times you'll need to have something comorbid. If you want to get coverage for an appliance for snoring, you need to have something else comorbid with the snoring. You send in the Epworth with it, and a lot of times that'll go. And then the bottom of the chart here pretty much is like a sleep observer. So it says, have you ever gasped for air? And this is a really high sensitivity again for sleep apnea. And the sleep observer scale, I use this when I'm checking to see the efficacy of my sleep appliances when I put them in. And I had a patient the other day who came in and he tested positive for sleep apnea. I went through the whole screen and he really didn't think he had it, so I sent this home with him so his wife could fill it out and see what she thought. Ideally, when you do your screenings, you have the spouse present because, as most of you know, the patient a lot of times is not honest. The great screening tool, the sleep observers, scale good for checking progress. Okay. So how do we check for sure? There are companies out there that are going to tell you that all you have to do is you buy a home sleep monitor, you send it home with your patients, you get the results, send it to one of their physicians. Their physician will read it, send it back to you with the prescription for you to make a sleep appliance, and that's it. You cannot do that. That is not the standard of care in the country now. These home monitors are not as accurate as soft polysomnograms, and the patient needs a face-to-face visit with the physician. And we are not allowed to diagnose. We can send our patients home with these home monitors, get them back, and see how they're doing. I use it as a screening tool. What I do is I send them home with a sleep monitor. Once I get the okay that, yep, go ahead, you can make the appliance, before I put the appliance in, I will use the home monitor. Send my patients home with the home monitor. They come back, I get the report, and once I feel that the sleep appliance has done what it needs to do, the patient's feeling better, not snoring, then I send the same monitor home with the patient with the appliance in their mouth. They do the test, and I compare to see how well they're doing. You cannot compare home monitors, the results, against what they started out with the PSG, the hospital study. They're calibrated totally differently. Okay. And here's the standard of care, the polysomnogram. You've got to get your patients to get these tests. I know some of you are saying, but they won't. They're expensive. take 6 months to get in. That's not up to us to make that decision. A lot of times the physicians will screen your patients, and they may choose to use their own home monitor. And if they feel comfortable having their patients do the home monitor, getting the diagnosis off of that, and then sending to you to make the appliance, that's their call. We are not the ones who can decide to use a home monitor on our patients or not in order to get the diagnosis. We can't diagnose. All these channels for the PSGs, they're tremendous. The ones with the stars, have just come in the 70s for sleep apnea. They used to use the PSG just to do brain waves, to check for epilepsy, different disorders, brain disorders. Now they can actually, by measuring airflow and chest wall movements, they can check to see what types of apneas the patients are having. Okay. And what's important about the PSG is it can really monitor central versus obstructive sleep apnea. Now, we are able to treat obstructive sleep apnea with our appliances. Central apnea, basically, the brain stops sending signals to the body to breathe. If we were to treat somebody with central apnea and put an appliance in their mouth, we could actually kill them. That's why they need a PSG to determine if they have central or not. Some home monitors claim to be able to read central apneas or not. They have logarithms that mimic whether you have central or not, but they cannot determine for certain whether you have central or not. You need a polysomnogram at the hospital or sleep clinic. Okay. If I didn't wake up, I'd still be sleeping. The famous catcher Yogi Berra. Thought that was pretty apropos for this presentation. Okay, let's look at some of the treatments. Treat obstructive sleep apnea. Okay, there's surgery, there's lifestyle changes, do the CPAP, and of course, dental appliances. I left drugs off this list because a lot of the physicians will start treating apnea with drugs. The problem with drugs are the large amount of side effects that they have for treating apnea, and what can happen is they disrupt the sleep phases, and by disrupting the sleep phases, it makes things worse. A lot of the drugs that they're using can actually make obstructive sleep apnea worse. So I kind of left drugs off this list because I try to encourage the patients to go some other route. So let's look at surgery real quickly. One of the most common surgeries that they have is called a UPPP. And basically what they do is they remount the back of the patient's throat, anything that could cause an obstruction. Couple problems with this surgery is if the obstruction isn't coming from the back of the throat, it's not going to do a lot of good. Another problem, very, very painful surgery. Third problem, it can relapse. Very high rate of relapse. As the patients get older, the tissues can become flabby again, and you can wind up with the same issue. Not very effective. Lifestyle changes, you can do this with your patients. Encourage them to lose weight. I've had patients in that really didn't want the CPAP, didn't want an appliance, so I talked to them a little bit about weight. The problem with that, as we all know, is it's tough to follow a regular exercise program. Avoid alcohol, sedatives right before bed. Avoid sleep deprivation. Go to bed and wake up at the same time every day. Don't pull all-nighters. Avoid sleeping on your back. The pull of gravity is huge. A lot of patients, their sleep apnea is worse while they're on your back. Okay. Practice good sleep hygiene. Sleep hygiene such as keeping it dark in the bedroom at night, keeping the temperature a little cooler. You don't exercise closer than 2 hours before bedtime. If you exercise close to bedtime, it kills me. I see these 24-hour exercise plans. The people are going nuts at like 10 o'clock at night, and I know that they're going to go home and try to sleep. Well, they got the adrenaline flowing, their heart rate's up, their body temperature is up. All of that has to decrease in order for them to start to fall asleep. You don't want to exercise right before you go to bed. And stop smoking. Smoking is a huge thing. It may relax you initially and help you to get to sleep, but then it starts working on the bloodstream and other things in the body, and it'll wake you up later on at night. Okay. So then we look at CPAP, the gold standard. I would have to say yes. CPAP is the gold standard. It works almost 100% of the time if the patients wear it. The problem is sometimes you need so much pressure with air flowing down in through the mouth, through the nose, getting down into the airway to open up the airway, the patient can't sleep. It's just the pressure is too high. A lot of problems with leaks around the mask. Some patients get claustrophobic with the mask, and some get rashes with the mask. And probably a big issue with especially younger patients with a CPAP, okay, is, of course, is not very sexy. They have something like a CPAP worn. So then we get into oral appliances. Okay, a lot of appliances. Here's 4 here, and then we have some more on the next slide here. All different kinds of appliances that you can use. You need to really, if you're going to get into this, have some knowledge of the different types. It's just like you wouldn't put the same crown on a tooth that you put in one mouth versus another. You wouldn't put the same appliance in on every single patient. Women are a little different than men, and it depends a lot on their bruxing pattern too. Heavy bruxers, you don't want to put a certain type of appliance in, the appliances will break. Okay. And basically the method that the appliances do is they open up the airway by moving the lower jaw forward, which moves the tongue forward. As the tongue comes forward and the lower jaw comes forward, all the muscles in the back of the throat, thanks to the lower jaw pulling on the hyoid bone, all the muscles in the back, the pharyngeal dilator muscles, tense up. The soft palate tenses up, thus the snoring decreases, and by having the muscles tense up, the airway has less chance for collapse. Very, very effective means of working. Those are the oral appliances in a nutshell. Okay. So how do they work versus CPAP? All kinds of studies out there. Okay, this is just one of them. CPAP is more effective in reducing the apnea-hypopnea incidences. The reason for that is air pushing through the airway. It opens the airway. You get less collapse of the airway, especially in severe cases. But when an oral appliance is done properly, adjusted properly, in mild to moderate cases, it is just as effective as CPAP. And it's very, very similar to CPAP in a subjective thing on how sleepy the patient is the next day. Improvements in quality of life, those types of things. And the oral appliances overall have been judged to be much more comfortable, and they're really preferred over the CPAP. Okay. Okay, I threw this slide in here because I thought it was interesting. Any of you that do any type of work with splint therapy, they've done studies showing that if you put a mouth guard in at night or an occlusal splint for any TMJ issues, you run the risk of making obstructive sleep apnea worse. You have to know before you put any type of oral device in a patient's mouth at night whether they have apnea or not. I know Gordon Christensen just came out with some stuff a couple weeks ago, saying pretty much the same thing. Why does that happen? It can happen because if you block the front of the mouth with a certain type of a splint, the tongue has nowhere to go. It'll go back into the throat. The splint is thick. Again, it'll block the tongue. The tongue goes back in the airway. And if you simply open the vertical, you could also decrease the airway. This next slide will show you how that happens. The next slide is just amazing. It's a CAT scan. You look at the top picture, and Courtney, if you can point to the airway there, excellent. That's a normal airway. Okay, 0.90 sagittal, that's baseline. So what they did is they opened up the vertical just 7 millimeters, no advancement, opening the vertical only, and the airway decreased 33%. Okay, this is a CAT scan. So they thought, okay, we open it up, let's do an appliance study. We open it up and let's move it ahead 5 millimeters. They did that, the airway increased 22% from the baseline. So now there are proponents out there of these appliances that say the more you move it forward, the more improvement you get. That is not true. Up to a point, yes. But you look at the bottom They thought, okay, we moved at 5 millimeters, let's move at 10 millimeters, and we'll keep the vertical the same. Moving at 10 millimeters, it only increased 11% from the baseline, and it actually decreased 11% from 5 millimeters. What this shows is when you are using an oral appliance, you have to let your patients know as you're titrating the screw or moving the little attachments on the sides, the patients have to know that, okay, my snoring's getting worse, or I just don't feel as good today as I felt yesterday. So they have to bring it back then. They can't keep moving that appliance forward forever because of this type of slide here. It could get worse. Really interesting. Okay, no squabbling sylvanas between people who accept an idea yesterday and those who will accept it tomorrow. I love that because even though, and Christopher Morley's an American poet, novelist, really brilliant guy. I like that quote because even though it is shown how effective oral appliances are and how people love oral appliances, they're much more convenient for travel, over 90% of the time, sleep physicians will prescribe CPAP over oral appliances in mild to moderate cases. So again, that's why we have to educate them. We have to show them the studies. Sleep physicians want their patients to get better. They want to do what's best for their patients, what's easiest for their patients. And they don't really realize the effectiveness of sleep appliances. We need to educate the sleep physicians also besides the primary care physician. Okay. So children suffer from this stuff too, unfortunately, and children are the ones that can really suffer. The 4 first ones are the main ones. You get snoring with kids, you get enuresis, bedwetting, ADHD, which I'll talk about. I'll show you a study at nighttime, bruxing. Bedwetting's huge. It is very satisfying. You get somebody with huge tonsils, and you ask them about snoring. They snore. They do all these other things, and you get the tonsils and adenoids out. The parents come back, and they're not wetting the bed anymore. You're a hero. I mean, it's unbelievable. You get 6, 7, 8-year-olds still wetting the bed. That is not normal. And the rest of these pretty much mirror what happens with adults also, the symptoms for sleep disordered breathing. Okay, let's look at a study here. Okay, habitual snoring in primary school children, they found that these kids that snore, they also tend to have poor school performances, hyperactivity, bedwetting, nighttime bedwetting, and they grind their teeth. No surprise with tooth grinding with snoring. They're grinding their teeth to try to open up the airway. Okay. Children with ADHD, they did this study over a 4-year period, and they found at the bottom here, this 4-year prospective study shows snoring and other symptoms of sleep disorder breathing are strong risk factors for future emergence or exacerbation of hyperactive behavior. I mean, isn't that incredible? A lot of these ADHD kids, unfortunately, are getting put into the ADHD category, and in fact, they have symptoms of obstructive sleep apnea. Treat the obstructive sleep apnea, and a lot of times the hyperactivity will get much, much better. We are in a position we can really help the kids. You know, sure, it's easier said than done. We've got to be very tactful with the physicians, very tactful with the parents, but you build up a relationship. It's all about relationships, and you're able to talk to the parents, able to talk to the physicians, and they'll respect what you have to say. Okay. Risk factors for children, pretty much the same as adults. Obesity, number 1 for the kids. It's amazing. I get these very large obese kids in. They're like 8, 9 years old with neck measurements. Guys can have a neck measurement, probably greater than 18 or 19 inches. And remember, with men, it was greater than 17 was the risk factor for obstructive sleep apnea. I'll show you a study with Down syndrome, increased airway size, low birth weight, family history. Again, huge hereditary component. And then you get into the arches, the small teeth, same as adults. Okay. So children with obesity, you look at this, they spend just 1 more hour in instead of 2 hours in front of the TV, if they spend 3 hours per day, they have 50% more likely to develop obesity. That extra hour does it. I found that fascinating. And look at the children, 8 to 18, how much time they spend in front of a TV and computer. As much time as they do sleeping. I mean, that's our society. Those are the types of things we need to really look at. We've got to get the kids up and moving around. Hopefully, you are in a situation where the sleep clinic, the local sleep clinic, may have weight control problems. That would be wonderful. Weight control clinics where they can work with these kids. Now, we can all thank McDonald's for some of this stuff. Look at the great supersize. Large fries. Let's supersize our fries twice a month and see what happens. Well, we could gain 2.2 pounds per year just by supersizing the fries. That's not counting supersizing the drinks also. That's huge. Now, let's look at for adults, for coffee. Let's put some cream in the coffee, just 2 ounces a day of cream versus milk. You could gain 9.2 pounds a year. It's all about choices, cutting back a little bit, making some simple substitutions. Easier said than done. It works real well if you have a very proactive sleep clinic in your city that can work with these sleep patients, work with the kids to get them on these diet control programs. I mean, it's just, we as dentists, it's tough for us. All we can do is suggest, but if you can find places to refer, these kids are going to be much better off. Okay. So Down syndrome. We've all seen Down syndrome kids with huge tongues. They have huge tongues, very narrow dental arches. The teeth are all messed up. 50% of the Down syndrome kids have been shown to have sleep apnea. And the Down syndrome kids have not been able to adjust very well to CPAP. We can help increase these poor kids' quality of life by working with them using sleep appliances. Yeah, we can't use sleep appliances in kids. This is an exception. Anything we can do to help out these kids, to help their quality of life, would be absolutely wonderful. They're not sleeping at night, they feel miserable. Okay. So what are the consequences? We know that, if we leave it untreated, what will happen with kids, they'll bedwet, they could bedwet, poor memory with children, the bruxing, they could wear their teeth down. Well, they can get hypertension, high blood pressure. All of this can lead to that because of what's happening in their bodies. Their heart's slowing down, increasing. The blood vessels are dilating, constricting, insulin resistance. Same things as adults, but they've shown that they leave kids untreated, they can develop these things as adults. A large, large problem. Okay, so how do we treat the kids? Okay, the best thing, treatment of choice, is get the tonsils and adenoids out. Up until 2011, that was tough. In 2011, the American Academy of Otolaryngology came out with new guidelines for tonsil and adenoid removal. This is really important. One of the guidelines now says that you can have the tonsils and adenoids removed if it's shown that the child suffers from sleep disordered breathing. Now, what's important about that is a lot of times, the kids are not getting diagnosed by a PSG. It's just symptomology. So if you show that the kid snores, that maybe they're hyperactive, they grind their teeth, they might bedwet, they're excessively tired during the day, they have poor school performance. Ask the parents about all of these things and then send them to the ENT and they should be able to get their tonsils and adenoids removed. I mean, this is a crime. You look at these two pictures to not get something done with these poor kids. Second choice is a rapid palatal expander. The two in combination, over 90% effective. Okay. So you get a huge improvement after, no surprise. Once the tonsils and adenoids are out and they're able to breathe, the bruxing usually goes down. And unfortunately, a lot of the ENTs, they'll say, well, we're just going to watch it, because we know that their tonsils and adenoids will shrink by the time they reach puberty, which is true, but by that time it's too late. They've already developed a lot of the problems, a lot of the mouth breathing issues, and a lot of the insulin resistance and diabetic problems by then. Okay. So this is what it looks like in my area of the country right now. We just had a huge snowstorm yesterday, and we're due for another one on Thursday. Lucky us. So that's the kind of dog I have out there who absolutely loves the snow, and she's been sitting outside all night while I've been doing this. So fortunately, we haven't been disturbed with any barking. So real quickly, we'll just go through some of the policy statements if you plan on getting involved in doing any treatment here. Real important, again, you need a face-to-face by the patient and the physician. You cannot send a home sleep study to an out-of-state physician, have them diagnose it, and then send you back to do a sleep appliance. Face-to-face, a physician has to diagnose because we as dentists cannot do the diagnosis. Okay, we can go kind of quickly through these cord needs. Yeah, we cannot do the diagnosis. We need a prescription from the physician. And then we had parameters that came out in 2009 were modified in 2013 by the American Academy of Dental Sleep Medicine. We need a diagnosis, and the diagnosis has all the sleep study and all the signs that the physician does. You see on there it says PSG. Physician can decide if they want to do a home sleep test or not, and bypass the PSG is their choice. But appliances and parameter 3.2 are fitted by us. We are trained dental personnel. We need to know, obviously, a little bit about the TMJ and other oral structures, whether the appliance is going to work or not. Okay. And we want to have, take serious training in this, know the protocol, which I'm going over right now, protocols. And parameter 3.3 is the big one. It says, even though it's not as efficacious as CPAP, appliances is still okay in mild to moderate cases. And we go on to 3.3. It says, and we can use the appliances in cases where the patients refuse CPAP or they may not be candidates. Unfortunately, a lot of insurances still will not cover oral appliances unless it has been shown that the patient is CPAP intolerant. And so a lot of times, unfortunately, the patient has to go through CPAP therapy, whether they want to or not, whether the physician wants them or not, in order to get covered for the sleep appliance. Okay. And follow-up. We need to make sure once we have the patient titrated and they're comfortable in the oral appliance, we need to send them back to the physician for another follow-up overnight study with the appliance in place. If they're diagnosed with primary snoring, they do not have to have another sleep study. The patients a lot of times will say they don't want to do that. They'll refuse, and then you need a signed consent. You have to have the patient sign something saying they refuse to go back for an overnight study. They're feeling great with the appliance in, and you need to see them every year after that. That patient is still under the physician's care. The physician's patient, you need to keep informing the physician. Okay. So just real quickly, the treatment protocol, you get the diagnosis from the physician. They send you the sleep study, prescription, and you go through a complete exam, go through all the side effects of the appliances, that type of thing, and then you send the plan to the physician, you make the appliance, you insert it, go through the titration with the patient. Once you feel that they've reached the point they get their maximum medical improvement, send them back for the overnight sleep study with your appliance. If they refuse to do that, you need to have them sign something. Snorers, they don't have to go back. Every 6 months then, you see that patient, follow up them once a year after that, after the first year. And you need to keep up on all the studies, all the new appliances, all the new protocols. Okay. So in summation, I know I went pretty fast tonight. I had a lot of things that I really felt were so important I wanted to cover for you. But this is an epidemic. We really are at the forefront of being able to screen for these problems as dentists. We need to be able to look our patients in the eyes and say, you have a very good chance of having a sleep breathing disorder. I'm going to give you a referral to the sleep clinic, to the sleep physician. We need to recognize these problems because really it's a matter of life and death. These patients with severe problems decrease their life expectancy up to 12 years. Okay. It's a matter of life or death. To know even one life is breathed easier because you have lived this is to have succeeded. You know, I love doing dentistry. I do orthodontics only, do some TMJ treatment, and I do the sleep treatment. The sleep treatment is so rewarding because we are in the position to really save people's lives. We really are. It is so rewarding to change their lives, to save their lives. And I hope that you got a lot out of this tonight. And I know Courtney has a couple other things she wants to go over with you. And I'd be happy to stick around for questions.
Thank you so much, Dr. Paschen, for that great presentation. We'll open it up for questions and group discussion in just a moment here. Before we jump into that, I did want to let everybody know you are more than welcome and should join Dr. Paschen and Nierman Practice Management in Charlotte, North Carolina, coming up in March 7th and 8th. You can get right on the Dental Writer website to get more details and register. But it is our successful implementation of dental sleep medicine course for 16 CE credits. And we always have a wonderful time at these courses. And Dr. Paschen will also be in Nashville, Tennessee, July 25th and 26th. Again, 16 CE credits, 2 days, and we do some wonderful clinical training as well as breakout sessions for administrative team members to learn the billing and implementation side of it as well. So hopefully we can see a lot of you at one of the courses here with Dr. Paschen. So at this time I'm going to go ahead and unmute everybody's lines. If you have a lot of background noise or you don't wish to be unmuted, you can remute yourself. Or you'll find a chat box in the lower right hand corner of your screen. Feel free to type your questions into there, and I'll make sure that we get that question fielded to Dr. Paschen. All right, everybody's line is unmuted now. Does anybody have any questions or comments or discussion items? All right, well, Dr. Paschen, I think you just did an excellent job covering the topic. I hear silence, and I don't see anybody in the chat box. So great job, and thank you so much again for hosting with us tonight for the study group.
Thank you very much for having me, and thank you to Nierman Practice Management. It's a pleasure.
All right, well, we hope to see all of you next week for the Tuesday evening study group. We'll have special guest Dr. Kent Smith with us reviewing sleep hygiene at 8 o'clock Eastern time. And also, just for our fun little day today, we have some famous birthdays. We've got John Travolta's 59th, Vanna White's 56th, and Molly Ringwald's 45th. So happy birthday to all of those celebrities. Thanks again, everybody, so much for joining us tonight. And again, a big special thanks to Dr. Paschen for preparing such a wonderful presentation and being here with us tonight.
Thank you. Thank you. Thank you.
Bye-bye, everybody. Good night.
Good night.